Yousuff, which is the Vice President for Growth of Equipo Health. Nowadays, we are hooked to our phones and social media, and we use our social media as if it is the single source of truth. So, this use case sits right in the middle of mental health, social contacts, and access to timely care. In many cases, the window for intervention is narrow, and the absence of early sickness can lead to devastating outcomes. So these sessions will explore how artificial intelligence can augment existing systems to identify early indicators of suicide risk, enabling more proactive, scalable, and sensitive intervention. Please welcome Fincy Yousuff.
All right. Can you all hear me? All right. Let's get started. In the next 30 minutes, we're going to be speaking about suicide and suicide ideation. If this creates any sort of distress in any of you, I respectfully request you to please step away from here because we're going to be speaking about real-life incidents. So I will not be disclosing the names of the patients or the places where this has occurred, but they're all real-life incidents. Okay? A guy walks into the street holding a gun in his hand. He keeps the crowd at gunpoint and starts shouting that I'm going to start shooting at the crowd. Now there's immediate chaos, people start getting scared. They start running around. Amidst the chaos, he finds a child who was walking around with his mom, grabs the child, holds the child at gunpoint, and starts shouting that I'm going to kill the child. Now the mother is panicking, the crowd is in distress, they don't know what to do. At this point, somebody amongst the crowd had the courtesy to call 911 and the cops arrive. Cops come up. When he sees the cops, the guy gets even more panicked. He starts shouting that I'm going to kill the child. They try to speak calm, make him calm. They try to speak sense to him, but he's already distressed. At a certain point in time, when the cops felt that he is going to kill the child, they had to do the inevitable. They shot the guy. Now, when they did further investigation, they not only found out that this guy was undergoing psychiatric treatment at a psych department nearby, but they also found out that this guy was being treated for suicidal thoughts. In this case, the suicidal ideation method was suicide by cops, because patients in this situation do not have the capability to do self-harm. They cannot kill themselves. So they depend on a third person to kill them. In this case, the cops. The guy was holding a fake gun. It was not even a real gun. And the guy was 15 years old. My name is Fincy. I am the Vice President for Growth at Equipo Health. I also lead the AI lab and the AI ecosystem. Equipo Health is a care coordination health tech product firm. We create actionable insights using analytics, and we are completely AI enabled. When you look at the screen now, you must be wondering what is this number that's ticking. If you look a little closer, this is ticking every 3 seconds. These are the suicide attempts that have been marked globally since the time we started this conversation. And for every 20 such attempts, it's a death by suicide that's marked globally. And these are not my numbers, these are numbers from WHO. So there is 720K deaths that are avoidable, which are completely by suicide. There are 20 attempts, like I said, for every one death every 20 attempts. And suicide is actually the leading cause that can be avoided if there was better intervention. And most of the deaths happen before the age of 50, which means the reasons why they do this is things that we have to start judging ourselves about. So why is this happening? In the last 20 years, if you try to recall, there has been a fundamental change in the way people have been socializing, the way people communicate, the way people interact. There has been a lot of people, there's an increase in number of people who are exposed to internet. Use of social media has increased, use of smartphones have increased. There is a lot of interaction that happens, you like it or not, you are completely over the internet. Your lifestyle, what you do, everything is over the internet. So there is unintended consequences because of this. There is increased loneliness, irrespective of the fact that there is increased interaction. There's likes and shares and comments, but there is increased loneliness. there's reduction in face-to-face communication. Because of this reduced face-to-face communication, people have gone into their silos, into their rooms. There is a social comparison that has decreased people's self-esteem. Kids now believe that if my social statement is not equivalent to the one that my friend has, something is wrong with my social statement. There is cyberbullying, online harassments have increased. All of this has transformed behavioral patterns in people. And the reasons, you'll be surprised to see the reasons why people suicide above the year of 50 and below the age of 50. Below the age of 50, most of the suicidal attempts happen because they feel their self-esteem is not up to the mark, their social statement is not up to the mark. They have financial trouble, people don't get jobs now. They find it difficult to handle relationship problems. But if you cut the people who have crossed 50 years of age, the major reason why they suicide is because they have chronic illness. They don't have anybody to look after them. Somebody is diagnosed with AIDS or with cancer, they don't know who's going to take care of them. At this point, it has come to a situation where we have to start thinking, what can we do as people who are working in technology to help people who are suicidal? So we at Equipo, we have been in the industry for 15 years now. Initially, we started as a care coordination platform where we were trying to help technicians, clinicians, we were trying to help doctors, psychiatrists to do their work properly in a more streamlined approach. But then again, what we saw was there are insights that are hidden in these conversations that the doctor has with the patient. When they speak to the patient, there are a lot of insight that they could have grabbed. So we started doing analytics on top of what we did. So the next thing that we did was we picked up all the data, we clumped up into analytics and found out actionable insights, but that didn't cut it. The reason why it didn't cut is because then we understood that, can you change the slide please? Just click on the next please. We understood that there are patterns that could essentially help them recognize what is happening what could happen to the patient 3 years down the lane. Yes, of course, you found out what is going to happen with the current data, but you would have to see predictive analytics. So we worked with the psych department of a reputed hospital, and we tried to understand the conversations that they have been having with their patient for the last 15 years. We dug deep into patients who have done suicide, who have attempted suicide, or even died due to suicide. We looked out their data, we found out phrasing. When we started, we just did a very initial phrase recognition model, which essentially means using NLP, we would find phrases where the patient might have mentioned that they are suicidal in nature, but maybe not called out directly, said that I'm suicidal, but said some phrases. We connected, co-joined them, and delivered a model that essentially looked at those phrases. But that's not going to cut it, because those phrases might change from people to people, population to population, age group to age group. I mean, Gen Z has a slang which we don't know of right now, right? So then we went on to do a feature recognition where we gave features to the model and told them to go look for those features. If somebody says, I like standing on top of the building, or I like to look at knives, we would look at those particular phrases, give those as features. But then, just like the case we spoke about, where there is suicide by cops, these are very unusual situations. There's no way in hell or heaven that we would ever be able to find patterns, suicidal patterns in such patients. Then we went on to ask the model questions. We went and asked the model questions. We asked the model, do you think this patient is suicidal? Does this patient have any problems in their homes? Do they have any problems financially? Do they have relationship problems? But again, it did not cut it. So then we decided to do a holistic model that brought out all of these things together. We brought out a model which recognizes the phrases, correlates it with the features, asks the right questions to the model, and in the end, we did one step that most people do not remember to do. We brought in the previous assessments of the patient back into the model, essentially to build the entire timeline of the model, which means the patient, if has been in treatment for about 1 year now and has been regularly seeing the doctor or the psychiatrist, we would bring those particular information back. Maybe this patient was suicidal 6 months back, is not suicidal now, but doesn't mean the patient is not going to be suicidal later. And this model has been moving up and click please. up and running for a very long time. So how do we do it? We bring in triage notes, follow-up notes, progress notes. We churn this into the model, we push it in the model. The model brings out pattern, phases, and risk signals. We do this by categorizing the patient, whether they are low, medium, or high risk of suicide. Now, when we put the output essentially has phrases, keywords, and AI is no longer black box, guys. Let's just get out of that. AI is no longer black box. Now, we now bring out AI which is explainable, which brings out the actual reason why we mark the patient as suicidal, thereby not making sure that the physician or the technician or the psychologist or the social worker is not eliminated. They're just empowered. We give them the right information so that they can take a decision and make sure that they speak to the patient in the right language to understand whether they are suicidal. So what did it reveal? The one thing that we understood over the 6 years that the model has been running is that there are many major factors that actually affect the way people speak and attempt suicide. You will not believe it. Their gender roles is one of the major reasons, not just their demographic, where they stay. How they identify themselves essentially is one of the major reasons. Other than that, prior psychiatric history, let's say the patient has schizophrenia or has mood disorders. As a child, they have incurred a loss. All of this started becoming a reason, and these data we started inducing into the model. We just did not pick up phrases, but we went on to pick up these as features. We started putting in demographics and all of this information back in. So, and the documentation. You can't just have every type of conversation going inside. You would have to be making sure that it's the right conversations that happen. So we made sure that we put the right documentation. At this point in time, we have, touch wood, we have more than 90% accuracy. We've been able to handle 92% of the cases that had been probably suicidal. We use, like I mentioned, we use an NLP model. I'll be lingering around in some time after the conversation to have a more detailed discussion on how the model is built. But I also wanted to bring out a few of these cases which are real life cases, like I mentioned. This is a particular case where, if you see, there are certain words that I have marked. The brother of this particular subject found out that there's a lot of knives hidden in that person's room. Now, you might think having knives in the room does not necessarily mean suicidal, it could also mean murderous, right? But with the phrasings that the patient has been having and the mood disorders or other psychiatric problems that the patient has been having, we were able to identify that the patient has been suicidal. We not only bring out what the phrases were, we also bring out assessments and narratives, which essentially are questions that the doctor had asked. We would bring out questions that had been previously answered as a yes as well. So the doctor does not have to go through reading humongous amounts of documentation. They don't have to sit through and read what has been the history of the patient. We do all that for the doctor and make sure that the information is up there. And one thing to note is most of the AI models that we know of do not bring out the confidence of the model. How confident is the model while making the judgment? Right? You don't just place it on the hands of the psychiatrist who's not a tech person. So we bring out the class probability where we actually mark what's the confidence of the model on its own assessment. If, let's say, the model says I'm 75% sure that this patient is maybe suicidal or not, it still leaves a gap for the psychiatrist to do a little bit more of assessment. And the one thing that most of our psych department loved is the keywords that we detected, the terms that bring out the actual ideation method that we feel this patient is going to have. For example, for this patient, we put out cutting, jumping, etc. as the phrases to look out for, or the questions to ask, so that they know which part to be concentrating on. These are other few cases that I wanted to show that the initial screening that's done at the hospital setting, which is done in like a 5-minute, 10-minute questionnaire with the patient, essentially showed that the patient is not suicidal. But with the words that they used and with the basis of the questions that we had seen previously with the patient, we knew that this patient is going to be suicidal. And you'll be surprised to know, case 2 that you see over here, this patient was ready to harm her mom because the patient did not get Wi-Fi connection. Because the mom said, you get Wi-Fi after you do your homework. This is a child. Case number 3 that you see is that of a boy who essentially had lost his friend and kept on mentioning that I want to go back to my friend. I miss my friend. I don't know what to do without him. This boy is essentially really introvertish, not suicidal, extremely studious, no problems at all. But the problem that we noticed was he kept on mentioning that I want to go to my friend. Alright, so then we went one step forward. Now, how many cases do you know that the patient suicides at the clinical setting? Suicide is not something that you do while you're sitting in front of the patient, in front of the physician, right? When you're sitting in front of your psychiatrist or your psychologist, you either are the best patient that they could ever ask for. You would say, I'm feeling absolutely fine, your medicines are absolutely fantastic, I'm feeling really great today. Or you could be the other kind of patient where you'd say, oh, I'm having a very difficult time, I don't know what to do. In either one of these cases, it's difficult for the psychiatrist or psychologist to make a judgmental decision at that point in time. So what we did is, with their consent, with the consent of the patient, we went ahead and gave them AI at their homes, which means if you're already hooked to your phone, we ask you, do you consent to use our patient engagement app, which is Contigo. So what we did is we created a patient 360, right? At the clinical setting, we help the doctor using AI by flagging the patient whether they are high, medium or low risk, and then we went on to giving a home settings patient engagement app, which essentially works as a companion, if you will. So in the first case where it was revealing moments that they were, recalling, the second one essentially revealed patterns, and we have had humongous amounts of pattern that we had recognized actually at the home setting much better than what at the clinical setting was, because you are at a 30-minute or a 1 hour long session. You would just speak across whatever you wanted to speak and get through with the 1 hour session. But when the AI, the ambient listening model, was given as a companion, the amount of information that we got in terms of what their involved behavioral pattern was much different. So this is how it works. Essentially, in the patient engagement app, there's an ambient listener on the side. It soothingly speaks to the guy and asks, how are you feeling? I'm listening to you. Do you want somebody to listen to? When they say that, I'm okay, I guess, just tired, nothing really seems to be getting better, no matter what I do. This is now pulled on to our initial model that we spoke about, where this pattern is now recognized, and we do alerts to the care coordinator or the psychiatric or the psych department that the ambient listener just spoke, heard the patient, and the patient seems to have patterns of suicidal thoughts. So what have we done with this? Essentially, what happens in a clinical setting is episodal care. When we say episodal care, people who are working in healthcare will understand that care is given in smaller episodes, the 1 hour sessions, the conversations that you have. But how much can a physician or how much can a psychiatrist do during that 1 hour? So we made sure that we filled the gaps using our patient engagement app. Now we have AI for good in that entirety of the patient's journey. This is continuous care. Care is now continuous and it's not broken down. So, okay. Now we understood that the patient is suicidal. So what? What are you going to do about it? There is no point in just recognizing or identifying that the patient is suicidal. The suicidal patient now needs they need help. So what do we do with that? We now flag this risk across both clinicians, guardians, whoever the setting is with. Some of our models are set with schools, some of these are with employers. Whoever the setting is with, they get alerts when we recognize that the patient is suicidal, essentially to stop an attempt from happening. There's no point that we do and the patient speaks to the the ambient listener and says, I'm suicidal right now, and next day morning you go back and alert the physician. There's no point in doing that. So what did we do? We made sure that the flag or the risk flagging happens then and there, so that psychiatric department or psychologist or even the parent of the child can immediately take an action when it is required. So like I mentioned, this is not something that has to be induced just at the hospital setting. This can be done at schools. We are in conversation with municipalities, we are in conversation with ministries, we are in conversation with schools who wants to work with us and understand behavioral pattern. again, one of the most astonishing things that we faced was we did not understand that this, in the school setting, the therapist was finding it difficult to make judgmental call about the patients or the subjects or the students that they're talking to, because they get hardly any time with them. And take into account kids with individual educational plans, it is not very easy for them to keep their attention going. So we are having multiple conversations where the setting is not just left out to hospital settings. So what have we done in the past 4 to 5 years that we have been in the industry? We've had 200,000 lives that we have personally screened. Our system has been able to flag 92% of the cases where the patient was at high risk. We have, our model accuracy is 90%, and we are doing more to improve the relationship that we have with the patient. There is no point again in just creating a model unless we are able to touch the lives of the people who we are speaking about. This is a 3-level model, which essentially means we flag them as low, medium, high, and every time the patient moves from high to low, low to medium, we keep flagging the patient at that point, and that has tremendously worked with the psych department of many hospitals. So one last thing that probably I want to bring to your attention is we are ethical, we are responsible, and we are explainable. So what do I mean by we are ethical? When we created our models, we made sure that our models are not biased towards any particular kind of gender, race, population, socioeconomic conditions. We wanted to make sure that the model speaks about every single patient. So we made sure that when we took, let's say, 10,000 data, we made sure there's an equal amount of data from every single population type. We made sure there are boys, there are girls, there are teenagers, there are people above 50, below 50, different populations, gender differentiation. We also made sure that when we did the testing, we did a validation with this, which essentially means we made the physicians, the psychiatrists, evaluate the model 3 times before we pushed it to them for them to start working on it. The psychiatrist who worked with us evaluated, corrected it, made sure that it works again, and we churned out the information. We made sure that the information is put in a cyclic method. Responsible. Are we doing this safely, and are we doing it reliably? We have to make sure there's reliability. So every 3 to 6 months we retrain the model. We make sure that the model has the most relevant information. The reason why I picked up the case where suicide by cops was discussed is because that particular case, we had marked it as suicidal, but we didn't know why we marked it as suicidal. We had to go back and learn from the model why it marked, just because of the pattern of the data. So we knew that there's these patterns that's missed out earlier, and we retrained the model. So ethical, responsible, and the most important part, which I keep very close to my heart, I have been doing AI in agri-tech, I've been doing AI in health tech, ed tech for a very long time. I've been in AI for a very long time now. But the one thing that keeps me grasped to AI in healthcare is because we touch lives. So it's very, very important that if we are going to create technology as a company, when we are creating technology, Equipo has made sure that we are explainable. We haven't had one model that we pushed out to them saying that just believe us. Trust comes from them understanding the data that they have seen. So we made sure that they see the evidence. It is an evidence-based system for every single model that we pull out. So they look at the evidence, they look at the data, they take the decision where they agree or disagree. If they disagree, then we make sure that we understand those patterns which psychiatrists or psychologists from their experience have said, no, this is not a pattern to probably learn, and we remove that pattern. So we made sure that our models are also explainable. Alright, so that's all that I had. I'll be more than happy to pick up any questions anybody has.